Recently, the American Cancer Society issued a new set of guidelines for the screening of men for prostate cancer. Their recommendations are that screening should not take place without first having an informed dialogue between the healthcare provider and the patient, and that information must include the uncertainties, the potential benefits, the potential harms that are associated with screening and subsequent treatment. If a man does decide that he wants to get screened, they recommend starting at age 50, unless there's a family history or if a man is African American, at which point they should start younger, 45 or 40. They also said that if you have a life expectancy that's 10 years or less, that screening should not be done because the harms significantly outweigh any potential benefits. Now, many men may resist that because they feel like they're being discriminated against. But the goal here is to maximize the number of people that are helped and minimize the number of people who are potentially harmed. They also provided information about what to do with your PSA level if you do decide to have it. For those men whose PSA is less than 2.5, the committee recommended that a test should be done only every other year rather than annually. If your PSA is greater than 4, they believe that's a reasonable point to consider a biopsy. But they do acknowledge that there is no PSA level that guarantees the absence of prostate cancer. For those men with a PSA between 2.5 and 4, that should be an individualized decision using a series of risk factors and risk assessments. So that's the basic information that's included. And this is important information that reflects the best scientific information that we have available. The committee acknowledged that there is evidence from one prospective randomized trial that the death rate has been reduced. But there are problems with that study, and most importantly, it required treating a large number of men in order to prevent one death. So the committee is concerned that the potential harms of doing that may offset the potential benefit of preventing that death. As time goes on, we're likely to see changes in that information because those studies only have about 10 years of information. And as the study matures, new information will become available that may allow us to say more about what to expect from screening and treatment. Now, there are important things that are needed. We need a better screening test. PSA is not optimal.